welcome back to Pharmacy in Pakistan. I hope that you're doing well and are ready for today's lecture. My name is Hamayal Khalidar and I will be moderating today's class. The topic for today is Pulmonary Disorder, Gout and Adult Immunization, conducted by Dr. Muhammad Abdul Haq. Dr. Muhammad Abdul Haq is currently working as an inpatient pharmacist at NMC Royal Hospital, Khalifa City, Abu Dhabi. Before this, he has worked with Lifeline Hospital, Dubai as a narcotics in charge pharmacist. He achieved the prestigious BCPS certification back in 2020 and has also earned the CPHQ certification in the year 2021. Without further ado, I would like to request Dr. Muhammad Abdul Haq Khan to kindly take charge from here on. Thank you.
Thank you so much, Hamayal. Bismillahirrahmanirrahim. Assalamu alaikum to everyone. Today is the topic for preparatory class for BCPS lecture. Our topic is pulmonary disorder, gout and adult immunization. Let's start our lecture. First of all, I want to disclose that I have not received any financial or commercial funding or support for today's session. No commercial trade names are used in today's presentation, and I do not promote any specific brand. No specific conflict of interest. I have no financial relationship to disclose, and I will not discuss off-label use or investigational use in my presentation. And I will discuss the following off-label use, investigation use in my presentation. We have three learning main objectives today. First is adult and pediatric. We will discuss asthma and COPD and gout and adult immunization today. First, let's start with asthma. When we talk about asthma, it's challenging to differentiate between asthma and COPD. So here we have some criteria on the basis of that we can differentiate on the basis of cough timing, acumen reversibility, and triggers. If cough is non-productive, worst at night, early AM, 12% improvement after SABA, and allergies involve and environmental allergies are involved, then we can say our patient is suffering from asthma. Otherwise, if cough is productive throughout the day and acumen reversibility irreversible, and there is history of smoking with the patient, then we will diagnose with the COPD. Here there is a COPD overlap, how to differentiate between these two. If three or more diagnoses match our criteria, then we will consider asthma, or if consider matches with the COPD, then we will consider it COPD. Later on, we will discuss in details what criteria are there and on the basis of how can we differentiate between asthma and COPD, and what are the treatments on the basis of our diagnosis. So first of all, age of onset for asthma before 20 years, COPD mainly after 40 years, pattern of symptoms, lung function between symptoms, past history and family history, time course, and mainly sex history. Sex history in asthma will be normal, but in the COPD, hyperinflation will be found in COPD case. Later we will discuss in details. Here we talk about asthma and asthma treatment. First of all, we need to classify asthma severity for the age 12 or more. Asthma we can classify in intermittent, mild persistent, moderate persistent, and severe persistent. After classifying, we will assess the control of the patient, how much well controlled, not well controlled, or fully controlled. On the basis of this criteria, we manage our therapy. We should do how to start, and we should increase in the therapy or decrease the dose of the medicine. So first of all, classify asthma severity. If the symptoms, night awakeness, beta agonist use interference with activity and lung function on this basis. If 2 days or week our symptoms are there, then it will be intermittent. If more than 2 days per week, mild persistent. In case of moderate persistent, it will be daily. And in severe persistent, it will be throughout the day. So here at the bottom, you will see step 1, step 3, step 4 or 5. It means On the basis of this classification, we will decide our therapy. We should go, if patient is not improving, we should move up to the step 2. If still not improving, we will move up to 3 and so on. And assessing control, in this, if we have started some kind of a treatment. If it well controlled, then we will continue the same therapy. If not well controlled, we will follow up the at the bottom you can see action setup, follow up within 2 to 6 weeks, and setup, go step 1, step 2, step 3. This is related to this slide. If we want to understand this slide, we have to memorize this chart, classifying asthma severity and assessing control. We know, we memorize these two charts. It is very easy for us to decide our therapy. Either we should start from step 1, step 2, step 3, step 4, step 5, or step 6. This is the main chart related to the exam. That question involved in this pulmonary disease. If we know our therapy, which therapy is suitable for our patient, we have to be very efficient in this chart. So here we have one case 1. A 23-year-old woman has been coughing and wheezing twice weekly, plus 3 times per month at night. She has never received a diagnosis of asthma, and she has not been to a doctor in years. She is using her roommate's albuterol, activity not limited. Okay, spirometry FEV1 82% predicted, which is the best classification for her asthma. We have option intermittent, mild persistent, moderate persistent, and severe persistent. So in this case, we can see the night awakenings are more than 3 times. And same question involved related to with this case. Which medication best to recommended for the patient from case 1? In this case, we found the mild persistent is the answer for that one, because the night awakening was more than 3. So in this case, mild persistent is the answer. Case 2, which medication is the best to recommended for the patient? Case 1, in addition to albuterol, 1 to 2 puffs every day, 4 to 6 hours as needed. No additional therapy needed. Montelukast 10 mg daily, mometasone 220 microgram, or budesonide formoterol 80 by 4.5. So if patient is still having complaint, we can choose our option C, mometasone DPI 220 microgram 1 puff daily, because this is low dose inhaler, and in this case we will go to step 2. Let's see what is mentioned in the step 2. It is low dose inhaled corticosteroid. So mometasone is the low dose inhaled corticosteroid. We can start our therapy with step 2, mometasone. Asthma COPD overlap initial therapy. In this case, initial choice is based on syndromic assessment and spirometry. As I discussed earlier, if 3 or more features favor for asthma, we will treat as asthma. If 3 or more features favor COPD diagnosis, we will treat as a COPD. And if a similar number of features for both asthma and COPD, consider SEOs and use inhaled corticosteroid, usually add LABA or LAMA, long-acting beta agonist, or long-acting muscarinic agonist. Consider both efficacy and safety. This thing we have to remember: no LABA monotherapy if any feature of asthma, and no inhaled corticosteroid monotherapy if potential diagnosis is COPD. This is the very main point we have to memorize. We have to keep in our mind while hunting our question in the exam. Here, classifying asthma exacerbation in urgent or emergency settings. Here, mild, moderate, severe, and life-threatening symptoms are there. On the basis of these symptoms, we decide either what are our exacerbation level, and we decide our therapy. Initial management of exacerbation, emergency department or hospital. Initial management, mild moderate, we will give oxygen to achieve oxygen level of 90%. Severe, if severe is there, then oxygen to achieve 90%, we will give high dose inhaled SABA plus ipratropium and oral corticosteroid, and consider adjunctive therapy, either IV magnesium, ketamine or Elox. Life-threatening condition, we will achieve oxygen 100%, nebulize with short-acting beta agonist plus ipratropium, and admit to intensive care. Here we have gold global lung disease guidelines for treating COPD. Consider COPD and perform spirometry if more than 40 years old with any following: dyspnea, chronic cough, chronic sputum production, history of exposure to risk factors. Most common, as we discussed, history of tobacco smoking is there. So in case of COPD, we found history of smoking. Criteria for diagnosis of COPD: symptoms and risk factors plus FEV1 over FEVC will be found less than 70%. Here, diagnosis of COPD, symptoms and risk factors. It will be FEV1 over FEVC, we will get less than 70%. Then on this base, we will assign the gold grade. Then frequency of exacerbation in 12 months, less or severe, no hospital admission, and more severe, 2 or more with hospital admission, then we can consider this COPD. Here we have 4 grades of gold grade. If in the grade 1, the FEV will be 80 or more. Grade 2, this is the very important slide. These numbers we have to memorize. If 50 to 79, it will be grade 2. If 30 to 49, it will be grade 3. And if less than 30, it will be grade 4. So first we will classify the gold grade, and on the basis of this gold grade, we will decide our therapy. Now we will validate symptom scale. Modified British Medical Research Council breathlessness scale MMRC. Only measure severity of breathlessness. Score 0 to 1, less symptoms, and score more than 2, more symptoms. There is one COPD assessment test and COPD control questionnaire also there. In COPD assessment test, CAT, measure health status impairment in COPD. A score of less than 10, it will be less symptoms. If 10 or more, it will be more symptoms. On these all criteria we have to memorize. So we can easily classify our patient. Then in the exam, if they are asking for the, maybe in the exam they can ask just only the class or the grade, which grade do you think this patient lie, or maybe they will ask on the basis of grade, they will ask the suitable therapy. So we should know about both, about how to classify the grade and how to suggest the most suitable therapy. And in the COPD control questionnaire, measure 3 domains: symptoms, functional state, and mental state. Domain scored individually or CCQ as a whole. If score of 0, very good health status. If score of 6, extremely poor health status. Here, gold refined assessment of COPD severity and risk. You can see in this chart, you learn how to read this chart and how to, on the basis of chart, how to classify our patient. It will be very easy to classify gold 1, gold 2, gold 3, and gold 4 to our patient. First of all, we do assessment of airflow limitation, then exacerbation history, last 12 months, assessment of symptoms of risk. On the assessment of airflow limitation, as we discussed earlier, FEV1, gold 2, 3, and 4, we classify. Exacerbation history in last 12 months, 2 leading to hospital, or 0 and 1 not leading to hospital. But if 2 or more, it will be C and D. If 0 or 1, it will be A and B. Okay. And MMRC 0 to 1 CAT will be less than 10 in C and A case, and MMRC more than 2 or more, or CAT 10 or more, it will be considered as B and D on the basis of symptoms. Here, COPD principles of pharmacotherapy. Medication for symptomatic treatment only. Some data showing fewer exacerbation hospitalization and improved lung function and quality of life. Long-acting bronchodilator are initial treatment, LABA or LAMA combination, short-acting only PRN. In moderate severe COPD, long-acting anticholinergics are recommended over twice daily LABAs to prevent exacerbation. Short-acting bronchodilator in moderate to severe conditions. Short-acting muscarinic agonists are recommended over short-acting beta agonists. SABA or SAMA combination recommended over SABA. So if we go, suppose in our question, both options after the questions are coming, one option is showing SABA and the next option is SABA and SAMA. So we will choose the right answer, combination of SABA and SAMA. We will prefer this. So we have to memorize each and everything to correctly answer our question in the exam. So pharmacotherapy for stable COPD. On the patient group A, B, and C, D, like we discussed in our previous slide. If A recommended first choice will be bronchodilator. Recommended treatment intensification continue or stop, try alternative class of bronchodilator. And there is no alternative. We stuck with, in case of B, LABA or LAMA we will give. If not improved, then we will go for combination LABA and LAMA. If we classify our patient grade C, then we will start our therapy with LAMA, long-acting muscarinic agonist. If not, the symptoms are intensified, we will go for LAMA or LABA. Or alternatively, we can go for LABA plus inhaled corticosteroid in case of for treatment intensification. This is the alternative. And if our patient is poorly controlled, like severe condition, means patient group D. So we will start with the combination of LAMA and LABA, as we discussed. This is the we will give combination. We will give a preference. And if not, it doesn't work, then we will add up inhaled corticosteroid ICS, and alternatively you can go LAMA or LABA or ICS, or that is so much technical things, and most of the time in the exam question relating to this group D, because it's quite challenging for memorize this chart. Sometimes the question answer of the exam will be so much confusing. So if you memorize this chart, it will be very easy for you to hunt the question. And the last one, LAMA plus LABA or PED4 inhibitor. In case of poorly controlled and our other what we are giving treatments are not working, we can go for this. So we have one question. 62-year-old man with recent diagnosis of COPD. Spirometry showed FEV1, FVC 60%. Okay, now just memorize these figures, these symptoms of the patient, so we can easily classify our patient, which grade does it belong. Pre-bronchodilator FEV1 70% predicted. Post-bronchodilator FEV1 72% predicted. Symptoms very bothersome. MMRC grade 2. One exacerbation past 1 year. Okay. Only one exacerbation. No hospitalization. Which most appropriate gold patient group? Here, option A, B, and C: gold 1, gold 2, gold 3, gold 4. So as we discussed earlier, symptoms are less than 2. So our question will be gold 2. Patient lie in the group gold 2, or you can gold 2 and group B, like in this case. Okay, in the gold 2, because the FEV1 is showing 60%. So 50 to 79 will be gold 2 and group B. Why it is group B? Because It's MMRC like this. So we will consider option B our answer. So here managing COPD exacerbation, short-acting albuterol is preferred. If we are receiving initially after patient having severe condition, we will start with short-acting albuterol, 2.5 mg via nebulizer every 1 to 4 hours, or 4 to 8 puffs via MDI holding chamber every 1 to 4 hours. Generally, short-acting ipratropium is also given with the combination of albuterol and ipratropium. Systemic corticosteroid used in most exacerbation, used in outpatient 40 mg up to 60 mg prednisolone daily for 5 days. Insufficient data for optimal duration. So, but usually we are giving 40 mg and maximum up to 60 mg prednisolone we are suggesting to our patient. Data show 5-day non-inferior to 14-day closure. Here, managing COPD exacerbation. Cardinal symptoms of airway infection, increased if the patient having any airway infection, it will show increased dyspnea, increased sputum volume, increased sputum purulence. Antibiotics should be given only if COPD exacerbation with all 3 cardinal symptoms, COPD exacerbation with 2 cardinal symptoms, one is increased sputum purulence. Here we should keep in mind that the 2 cardinal symptoms are there. So among 2, this one should be the increased sputum purulence. Okay, in the severe case, severe COPD exacerbation require mechanical ventilation. So in this case, patients are hospitalized and we are giving mechanical ventilation to the patients. So antibiotics for COPD exacerbation, optimal antibiotic therapy should be based on local resistance patterns. Empiric antibiotics are used to cover the most common pathogens, streptococcus pneumonia, Haemophilus influenza, and Catharalis. So where you are working in the area, like if you are working in Pakistan, if you are working in America, Europe, UAE, GCC, so on the basis of this local guidelines and local most common found pathogens, you decide your therapy. We cannot generalize our therapy, like totally depends on the region where your patient belong and where you are working and where you are giving the treatment. But these at least we should cover these organisms when we are deciding our therapy and when we are choosing our antibiotics. In Gold 3 and Gold 4 patients, Pseudomonas aeruginosa is most prevalent. So, what antibiotic we are going to select, it should cover this Pseudomonas aeruginosa, because in Gold 3 or 4 patients, this is the most commonly found organism in these patients. And the antibiotic duration recommended is 5 to 7 days. So now gout. We'll discuss about the gout presentation and disposing factors. Acute severe arthritis, usually episodic, can be chronic, tophi, or may not be present. So it is not necessary if patient is suffering with gout and tophi should be present. It's not necessary. So acute goutitis attack, severe pain, redness, and swelling we will see to the patient joints. Reverse in first 12 to 24 hours, continuous for few days to 2 weeks. Most often in lower extremities and in a single joint. Usually it found in the feet joints. So on the basis of this, first we perform the uric acid level and then we make final diagnosis that patient is suffering with the gout. So predisposing factors, what are the predisposing factors? First of all, diet, alcohol, drugs, xanthine oxidase inhibitor, series, diuretics, and niacin and aspirin. These maybe increase the level of uric acid in the blood, so can lead to gout. Other than this, obesity, diabetes mellitus, hypertension, DLP, CKD, chronic kidney disease are the symptoms for this predisposing factors for this patient. Classification of gouts: 3 stages are there for gout: acute gouty arthritis, critical gout, between attacks, and chronic recurrent gout. Severities of chronic gout atrophy: mild is 1 joint and stable disease, moderate 2 to 4 joint will be involved, and the disease will be stable. In the severe case, chronic CTGA of 4 joints or more than 1 unstable complicated severe articular tophi. And then we will consider our condition and the disease will be severe. So we will give the most intensive therapy if we are considering our disease on the basis of the symptoms severe. Treatment of hyperuricemia. So in case of hyperuricemia, serum urate target is minimum less than 6 milligram per deciliter. Our goal is less than 5 milligram may be needed to improve signs and symptoms. Consider goal less than 5 milligram per deciliter if tophi present. So maybe in the question they will give the lab values on the basis of this. Maybe they will ask what is the goal of treatment or how to select the best treatment choice. So we should know about what is our minimum on the level of uric acid and what is the goal of uric acid. So on the basis of this, we can select our answer. Consider discontinuation of non-essential medicine that cause hyperuricemia. So we will check the patient medical history and what kind of medicines patient is already taking. If something we can discontinue, it will not affect the patient health. So we should go for it because it causing some other symptoms, some other problems to the patient. So we should consider this option. Indication for urate lowering therapy: tophus or tophi by clinical exam or imaging study. More than 2 acute gouty attacks per year. Chronic kidney disease stage 2 or worse. Past urolithiasis. If these symptoms are there, we will, on the basis of these symptoms and then these outcomes, we will decide our therapy. Urate lowering therapy can be started during an acute attack as long as concomitant anti-inflammatory therapy is given. First line is xanthine oxidase inhibitor, allopurinol, or febuxostat. Alternative are uricosuric like probenecid. Initiate anti-inflammatory prophylaxis for acute gout concomitantly with or just prior to ULT in all patients. Early increase in acute gout attacks during initiation of ULT. Here, anti-inflammatory prophylaxis also we are considering in some cases for gout. First line, oral low dose colchicine. Other first line option is low dose NSAIDs, lower evidence grade than colchicine. Oral corticosteroid and alternative only if colchicine and NSAIDs are contraindicated. If patient has some symptoms that doesn't allow us to give this medicine colchicine and NSAID, so we can go for corticosteroid. Or if they are not tolerated or ineffective, also in these cases we can check for corticosteroid if given. So maybe in the exam they will show you the clear picture and they will give you the answer that clearly you can go to select colchicine or NSAID, but in the end maybe they will say that patient is these symptoms, these medicines are contraindicated or not tolerated, or patient is receiving this medicine, it will be ineffective, and they will also give corticosteroid in their answer. So we have to read carefully our entire question till end, not never go for early decision. Never like make early decision for selecting our answer. So first fully read, understand the question, then each and every condition, all contraindication, each and everything, then only go for the selection of your answer. So here we discussed that corticosteroid can be alternative if NSAIDs and colchicine are contraindicated, not tolerated, or ineffective. So this is the focus point we can note. Acute gout prophylaxis should continue for greater of 6 months of duration, 3 months after achieving target serum urate if not tophi. 6 months after achieving target serum urate if tophi were previously present but now resolved. So this is the duration of treatment. We can continue our urate anti-inflammatory prophylaxis therapy. Continue prophylaxis if any clinical evidence of gout disease activity is present, tophus or tophi, recent acute gout attacks, chronic gout or arthritis. If these things are there, then we will continue our prophylaxis therapy. Here we will discuss about urate lowering therapy. Monitor serum urate every 2 to 4 weeks. We have to take the labs of urate, serum urate. After goal is achieved, continue monitoring every 6 months. So even we have achieved our goal, which was less than 5 milligram per deciliter. We have to continue our therapy, and we should check the uric acid level every 6 months. If serum goal is not achieved, then titrate single agent thin oxidase to maximum appropriate dose. Maximum dose for allopurinol is 800 milligram per day, and doses more than 300 milligram per day can be used, even in CKD, chronic kidney disease. Next, if patient is still not responding, then we can add uricosuric to xanthan oxidase inhibitor, either probenecid, losartan, or fenofibrate, to intensify our treatment to control the symptoms of the patient. Probenecid is the first line uricosuric. Losartan and fenofibrate are off-label but recommended second line uricosuric. So first we will prefer probenecid. If it's not working, then only we can go for losartan and fenofibrate, but these are off-label use. If goal is still not achieved, add pegloticase if severe gout disease burden and refractory intolerant to other UAT option. Indefinite duration of urate lowering therapy. Here, treatment of gout, initiate pharmacological treatment within 24 hours of onset of acute gout attack. So we have to initiate our treatment within 24 hours. Colchicine is only appropriate if started within 36 hours of attack onset. This is the very critical point we have to keep in our mind. Maybe in the question they will ask colchicine is appropriate if it started within 36 hours. So maybe in the question they will say patient is suffering like 40 hours or more. So we have to keep in our mind that this figure 36 hours, less than 36 hours, then acute we can go for colchicine. If more than 36 hours, we will not go for this. Continue established urate lowering therapy without interruption during acute gout attack. Assess severity of gout attack and select treatment based on severity. Treatment of acute gout. Monotherapy. If mild to moderate pain, 1 or a few small joints, 1 to large joints, NSAIDs, oral corticosteroid or colchicine. We can give supplemental topical ice as needed. We have to apply some ice on the joints to reduce the inflammation. No preference for one. Select based on presentation, comorbidities, previous response, and patient preference. So what we discussed, NSAIDs, corticosteroid, and colchicine, there is no preference. On the basis of the presentation and comorbidities, we have to select our therapy. Combination therapy, if severe pain, polyarticular attacks, multiple large joints. So if these things are happening with the patient, then we will go for combination therapy. Monotherapy for acute gout. In case of colchicine, if patient is received acute treatment in past 2 weeks, use alternative therapy. Okay, so if patient has received acute treatment in last 2 weeks, if patient is taking colchicine, then we will not select colchicine as a treatment in this case. Using patient with renal hepatic impairment, taking prophylactic colchicine is not recommended. Okay, this is the critical point. In our question, it's mentioned this patient is having renal or hepatic impairment, so we will not go for this. In case of corticosteroid, consider intraarticular if 1 to 2 large joints are involved. Oral for all other presentation may consider intramuscular triamcinolone followed by oral corticosteroid. Treatment of acute gout, initial combination therapy. Full doses of both agents or full doses of one or prophylactic dose of another. Treatment options: colchicine plus NSAIDs, oral corticosteroid plus colchicine, intraarticular steroid with any other. Avoid combination NSAID plus oral corticosteroid. So this is the thing we should memorize we should clear in our mind. Maybe in the question, the answers, one of the answer will be NSAID plus oral corticosteroid OCS. So we will not select that option because here it is clearly it's saying that avoid combination of NSAIDs and oral corticosteroid. So just keep memorizing these treatment therapy and these criteria. So when in the exam, it will be very easy for you to select your correct answer. Here, patient case 4, 60-year-old man with third gouty attack in past year. Last attack about 10 days ago. Took colchicine with good response. Pain is left knee. See here, it is showing 10 days ago. When is left knee, third, fourth, interphalangeal joint on left hand, pain scale is 6 by 10. Started about 10 hours ago. Okay. So pain started 10 hours ago. Past medical history, COPD, dyslipidemia, normal renal function, weight is 80 kg. Uric acid concentration 1 month ago was 10. Not okay. So uric acid is, we can say, high. Current medication tiotropium, albuterol, simvastatin, which is most appropriate treatment of this acute gouty attack. Naproxen, colchicine, 1.2 gram, then 0.6 milligram in 1 hour, then 0.6 milligram to 12 hour. Intra-articular triamcinolone injection for all affected joints. Prednisolone 40 mg daily. Naproxen 750, then 250 milligram. So in this case, we say that patient started about pain started 10 hours ago, but patient has been taking this colchicine with good response. As we discussed, if patient is taking within 2 weeks colchicine, we will not go for this option. So here patient is having pain. See prednisolone and the option D, prednisolone plus naproxen it is showing. So before we discuss that, we will not go for this option. So we will not go for this. Only we will go for naproxen to control our pain. Now adult immunization. General immunization guidelines. Here we will discuss basic recommendation for immunization for adults based on age and specific vaccine. Certain medical conditions require special consideration when determining whether additional immunization are recommended. Immunization is so much critical topic for exam point of view. So that's why they put this topic in the BCPS curriculum, and it's very technical topic. So we have to focus. We should be more focused on this topic. Third one, on the basis of patient-specific factors, specific vaccine or formulation should be avoided or used with caution. Contraindication and precautions. Do not administer a vaccine when contraindication is present due to increased risk of serious adverse reaction. Okay. Live vaccines should generally be avoided in patients that are severely immunocompromised. Pregnant women should not receive live attenuated vaccine due to theoretical risk of fetus. So for this, we should have strong knowledge of which vaccine are live vaccines. So in the question, if they are saying we can give this vaccine to a pregnant woman, so we can select no, we cannot go for this live attenuated vaccine. In general, vaccine should be deferred if a precaution is present based on the risk of experiencing a more severe reaction to the vaccine. A vaccine can be administered when a precaution is present if the benefit outweighs the risk. So we will decide on the patient condition. Either it is necessary for the patient, if it is the life-threatening condition and benefit outweighs the risk. So we can go for it if we need after administering the vaccine. We think that no, it will not be so much harmful for the patient and it will be benefit for the patient. So we can go for administration. All vaccines have precautions for administration in a patient with moderate severe illness without fever. So there are some major changes in the 2022 adult immunization schedule. HPV vaccine is now recommended. HPV vaccine is now recommended for all individuals through age of 26. Shared clinical decision making should be considered for individuals 27 to 45 years of age. So if you are working in a hospital setting, we should discuss this condition. Patient is qualifying this HPV vaccine, then there must be like doctors, pediatrician, other consultants. They should sit together and then their shared clinical decision should be made if the patient age is 27 to 45 years of and we want to give HPV vaccine. Pneumococcal vaccine should be administered to immunocompetent adults 65 and older after shared decision making. TD or TDAP can be used with TD if indicated. Varicella can be considered for individuals with HIV without evidence of varicella immunity when CD4 counts are 200 cells per millimeter or greater. In the workbook, you will find one chart there. If you memorize that chart, so it will be easy for you to hunt the question, because in the question in the exam they will give you so many conditions, age, condition involved with the patient, and some labels will be there like CD4 counts and some other also will be there. So on the basis of that, you have to select which vaccine is either we should go for this vaccine or not, patient qualified according to the condition, you should go for it or not. So in adult immunization, we usually consider these things for giving adult immunization to our patient. So thank you for this lecture, arranging especially Hamayul Khalid. Any question?
Thank you so much, Dr. Abdul Haq, for giving us your time and sharing your knowledge. And thank you to all participants as well. There's one question in the chat by Mr. Ahmed Raza. He has asked that what is the role of azithromycin in reducing inflammation in COPD patients? He says that one of our consultants is prescribing azithromycin for weeks for this property of azithromycin to COPD patients.
Many things actually, when we are working in hospital settings, we should discuss with first of all with the doctor what kind of